All right, good afternoon, everyone. Thank you so much for coming out. What a great turnout. We did not expect this, so thank you for being patient while we procured chairs and put them together and all that. My name is Doug Hawkins. I am the nursing home administrator of ACC Care Center. Happy to serve our community as we enjoy providing care to our community. We're here today with a panel including Sutter Health as well as a few of our ACC representatives here to kind of dialogue and panel and give you information on what to expect after discharge. After the panel kind of dialogues and all that, they will be open to Q&A, so if you have any questions, we are certainly prepared to answer those questions. Help yourself to our refreshments. If you are allergic to peanuts, please do not have the sauce. There is a sign there. This all came out of our kitchen. We have a wonderful dietetic department. So anyways, I will turn this over now to Scott for introductions to the panel. Thank you all.
Perfect. Thank you so much, Doug. And perfect. Thank you so much. So today we're going to do this a little bit more like a conversation. And that way all of us on the panel here can talk about what to expect after discharge in more of a build-on style. So how all of our services can help during that discharge process and help support after discharge. So to start, I wanted to have all of the different panelists introduce themselves and what their position is and what company they're with. So I'll start here with Virginia.
Good afternoon, everyone. My name is Virginia Winnicke. I manage the transportation program with ACC for over 20 years.
Good afternoon. My name is Sujin, and I'm a program manager at ACC Senior Services. I work with the Caregiver Support Program, Aging and Disability Resource Connection, and also the PERS program, which is our newest mental health support program.
Good afternoon. I'm Carlene Balmer, and I do community outreach at Sutter Health for the Sutter Senior Care PACE program. PACE stands for Program of All-Inclusive Care for the Elderly, and it's a program that's been around since the 1970s and here in Sacramento for the last 32 years. And also here with Sutter Care at Home, which also includes hospice program and a visiting nurse program. So here to answer any questions you may have.
Good afternoon, everyone. I'm Corey Ishisaka. I'm the admission coordinator for the care center here. So when people are in the acute hospital or they know they're going to be having surgery, you know, they can call me, and we want to make sure that we can get you a bed and we can admit you here for our short-term therapy. So I welcome everyone to ACC, and it's so nice to see everyone's face.
Perfect. And as Doug mentioned earlier, we will all be open to questions at the end. And we also have a whole line of staff and support members in the back here from our different parts of ACC, as well as Meals on Wheels by ACC. And so afterwards, they also will be here to answer questions that you may have of additional supportive services than what we're going to talk about today or things we're going to touch on today. So just refrain on your questions until the end, and then we will open it up for questions. So to start out, I'll address the first question I have for Corey. So what is kind of the first step when somebody enters the hospital? What do they have to start thinking about?
Well, the case manager at the hospital, they'll have a dialogue with the patient, and they'll ask you, if you need skilled nursing services, if you need continued therapy after you leave the acute hospital, they'll ask you, what's your preference? Do you have a preference of a skilled nursing facility? So they'll give you a choice. They will send out a online referral out to me in different hospitals of your choosing, and the admission coordinator like myself, we're able to look at the clinical information and look at the insurance to make sure we can accommodate you. So then I will respond back to the hospital, and the hospital will let you know who's accepted you, then we can make that arrangement. So when you first go into the hospital, tell them you have a choice of facilities. If you're interested in ACC, you can tell them you have a preference of ACC. You can actually tell them to call Corey, and they know who I am at the acute hospital, and they'll get a hold of me, and they'll facilitate that referral.
Perfect. And when you're in the hospital, when is a good time to start having that conversation about discharge?
The minute you go into the hospital, because you want to be proactive. And it's good, even if you think you don't need a skilled nursing facility, you want to make sure you're talking to that case manager. You want to be set up for success the minute you get into the hospital so they know what direction to go with your care.
And you kind of touched on it. How much say does a patient have in the hospital as to what their next steps might be, where they might go?
Well, the hospital will either talk with you about going home or going to a skilled facility like ACC for your recovery. So they'll have that discussion with you. It'll be depending upon how you're doing with therapy when you're in the acute hospital. If they feel you still need more extensive therapy, they will send you to a facility like ours, like ACC. Because when you go home, you only have up to 2 days a week of physical therapy with home health. If you go home, if you come to a facility like ours, you can have daily therapy. So it's more intensive. But they make that determination to see if you're what your criteria is. If you're doing so well and you're running around the facility at the acute hospital, they'll say you don't need to go anywhere but home. You're fine. You're in great shape. But if you need some more fine tuning, we're the perfect place to come to. But the hospital will have that discussion with you early. So they'll talk either about going home with home health, coming to a facility like ACC for short-term rehab. Sometimes if they feel that you're doing too well to even qualify, going to a nursing home like ours for continued therapy, they might ask you, do you feel comfortable going to a board and care or to an assisted living for a short term where they have caregivers to help you? So there's a difference between needing caregivers to help you, hands-on care, and then needing a licensed clinical nurse to be part of your care. So the people who come to us, they'll have a skilled nursing need, like they need a licensed nurse to monitor them, which can't be done at home, or they have physical therapy or occupational therapy that needs to be done on a daily basis.
Perfect. And building on that idea, what is the typical length of time that somebody is in a rehab or in skilled nursing for that short-term stay?
That's a really good question. So it's not cookie cutter. It depends upon each resident and how you're doing and how you're responding to therapy. Also, if you're meeting the criteria. So everything's always going to go upon your insurance. We keep in contact with your insurance company. They look at a weekly review to see how the patients are doing, and then they do a reauthorization. So the average length of stay is about 2 weeks. Some people are sometimes here for 48 hours. They're doing so well. Then other people may stay here a little longer because they still have some gains to make with therapy.
I think that's an important point. And for anybody in the crowd that has had a short-term stay or known that's somebody that's had a short-term stay, it's not cookie cutter. Every individual care plan is different. So there's no set amount of days that typically somebody's within a skilled nursing setting. Perfect. So then, Sujin, I'll throw the next one to you. So if somebody does not go into a skilled nursing right after hospitalization, and they're not sure quite what to do next or where to find resources, how is the best way for somebody to search out what those supportive services might be?
Thank you for the question, Scott. So the discharge from the hospital to home, or even discharge from the skilled nursing to home, when you had your short-term rehab services done, that's the period of time that many, things come up, and then depending on the person's care needs, sometimes it is recommended to have the person to have a non-medical caregiver to come in to help with the personal care, or they would need some help with the nutrition service because they cannot cook the meals for themselves, or they for the time being they cannot drive, so the transportation becomes an issue. So there can be many different needs depending on the person's the status at that point. And I know it is usually upon the care receiver themselves or the care family members who want to advocate for the person and then arrange these services. And it can be quite overwhelming because you're already talking with the hospital team, skilled nursing, the care team, and the home health is coming in. So you have multiple appointments to, the manage. And you have if you need some equipment, then you are talking to these equipment rental services as well. So it can be quite a lot to manage. I get to work with many caregiving, the families in that kind of a situation. My goal is to help them to navigate and relieve some of that burden to coordinate all these services and finding the right services that match their needs. Depending on the assessment, we can decide the pressing issues, if it is transportation, bringing some in-home care, if it is some, the skills training for the caregivers, where to look at, what are the trusted resources that we can, recommend to use. Those are the discussion that I have with a lot of families. So, that's the, that coordination and the navigation of that, the services during this very, the challenging time that can sum up my work with the families in this area.
Perfect. And do you only work with the person or the patient themselves, or do you work with their family members if it's too overwhelming, or if their medical situation at that time does not allow them to make that contact and search for those resources?
We can work with both, and ideally, if we have both care receiver and the caregiver involved, that that makes the process easier. So when we get the contact from the seniors themselves who are looking for some of this coordination support, we always try to locate if there are any informal support in their system, any friends, family members nearby who can help them to to do this together. So we will approach our the service as a support for the family or support system, the informal caregivers, if there are any, then we will try to engage them as well.
Perfect. And could you address maybe some of the common misnomers or common ideas out there regarding in-home care? Are all agencies cookie cutter, exactly the same? Are there different specialities that each company may offer and different levels of care?
It depends on the capacity. There are more than 60 in-home care agencies in Sacramento County alone, so it can be quite overwhelming for you to contact each and then try to find the right fit for your needs. And the pandemic hasn't been quite, kind for this industry. The industry already was suffering from the shortness of the labor, so they had a lot of turnovers of the caregivers, and it was not easy for many of these agencies to keep the reliable and consistent service for their clients. During the pandemic, it was even more exacerbated. So we are looking more and more. We are hearing from our clients how their service experience with the agency can be hit or miss. Sometimes you have the consistent caregiver coming in at the right time, to do exactly, what the care plan says. But sometimes, you have the new caregiver coming in every other week, every 1 week. So you have to do the orientation all over again to familiarize the caregivers with the tasks that you want them to do for your loved ones. So it is not easy to find a good fit, and the agency model is that you will mostly deal with the administrator, the care manager, who will listen to your needs and then find the caregiver and match the caregiver to you. But actually, the person who comes in and then provide the service is the caregiver themselves. So when even the administrator or the care manager is excellent, very responsive, communicate with you well, but if the caregiver comes in and then do the very desirable job, then it really affects the service, the experience on your end, right? So there are a few, the size-wise and their history-wise, there are established in-home care services in this area. So try to always, get multiple referrals. So for yourself to be the person to make the choice, compare and then find the best fit to begin the process with. And always, to listen to other people's references and try to do some, to spend some time to research and then find the right fit. Not just the one agency that you hear from someone and then go with it. There is the higher chance that, that is not going to be the desirable, the experience for you. We can certainly guide you through the process and give you the basic information. Hourly rate for the in-home care agency has increased a lot. It was around 25, 27 per hour before pandemic. These days, you cannot find any agencies that starts below $35 per hour. And they used to have more flexibility about the number of hours per visit that they can provide. But these days, most agencies apply 3 to 4 hour minimum number of hours per visit. So it is getting more difficult these days working with the agency. I definitely hear from a lot of families that I work with.
Perfect. And then sort of the same question to you about that we asked Corey is when is a good time to initiate this conversation with a care manager or care navigator? When is a great time to contact and start preparing?
So I hear from the seniors and the families when they have the surgery planned and they know that after the surgery for the certain period of time, they would need some additional support and they want to be proactive and then contact us to get some research done. What are the service providers that you can, the contact when the needs arise. So that is one way to do it. But if you're in the situation, because accidents happen with all the preparation and out of nowhere, the seniors fall, and if there is any sudden, the health, the situation changes, like the stroke, you go through this process, hospital, skilled nursing, on a very, the fast pace. Anytime in that process, if you need someone to talk to, get some ideas of how this process works and how you can get some additional support to navigate this to the best interest of yours, please let us know. We would be happy to support you through the process.
Perfect. And then transitioning a little bit to how Sutter's programs work, could you tell us a little bit more for those that aren't familiar about what PACE really involves so they can get an idea of what that program is like and what Sutter has to offer?
Thanks, Scott. The Sutter Senior Care PACE, as I mentioned, is a program of all-inclusive care for the elderly. It's a program for 55 and over who want to be able to age in place. We are trying to avoid placement in a nursing home for as long as possible or indefinitely. And the idea is to have a team, an interdisciplinary team, who can all work together and prevent gaps in coordinating your care and navigating your care. It is a program for those who do have some chronic care needs, some medical issues that could be where they could be better served of having that team approach. So like on the team, for example, you would have your new primary care provider who's a geriatric specialist. You'd have a transportation supervisor. You'd have a social worker, dietitian, nursing. So that's how it all works together. And it's kind of a one-stop shop at our one location. So folks will be picked up, brought to our center for socialization, which I think we've all realized through the pandemic how important it is to see people, talk to people, even if it's just a hello at the mailbox, something. And we have recreational therapists who plan and coordinate activities. So the idea is that you would have a team who can make your doctor's appointments for you, coordinate and navigate healthcare for you, and then pick you up and take you to your doctor's appointments. Come into our center, see the dentist, see the doctor, do physical therapy. So it is very much a network and a coordinated model. And then those folks in our program utilize the Sutter Health network of specialists. But I think a really important aspect or element is the home care. So this is where our team will do a care plan before you even enter the program to determine what areas of your life where do you need support. And oftentimes that is home care to help with activities of daily living. So just getting dressed, sometimes brushing your teeth, things like that. But it could also mean pushing the vacuum cleaner around, changing the sheets on the bed. It's hard for me to lean over and change the sheet on a bed. So we can send folks. With our program, I'd say one advantage would be is that we're more task-oriented when we come into your home. You get a schedule of when we come in that day, this is what we're doing. It might take us 15 minutes, and that's it. Sometimes we can come in several times a day. Someone needs insulin shots a few times a day. We're going to look, what do you need to stay independent living in your home? It is a Medi-Cal program. So if you have Medi-Cal, we can look and see, chances are there's going to be no copays or out of pocket. A new thing is that we no longer even have to collect a share of costs. So if you have Medi-Cal and you're familiar with what share of cost is, it can be very challenging to access care. So just last week, Sutter Health made the decision to basically waive that in order to improve access for folks. So that's something we can also discuss to see, does it make sense to apply for Medi-Cal? There's been a lot of changes with Medi-Cal recently, looking at how much money you can have, how much you own, things like that. So I guess I could talk for a lot about the program, but that's kind of it in a nutshell.
Yeah, absolutely.
Yeah.
Well, and one question to that would be also the same as we asked Corey and Sujin, is when is a good time to call? Is it when you're planning ahead? Is it something where before a life event happens? Or can you call in crisis mode to Sutter and say, I think this program might be a good fit for me?
So I would say a lot of times we get connected to families and to older adults when they're in the hospital. And we do get a call, a referral from a case manager or even a social worker just saying, I think this person could benefit from the program of the team approach, and having someone come in. And we can be a big support to the family members as well, because now you have someone to take them to their very essential doctor's appointments and such. But also, because the program starts at 55 and over, yes, you can just call anytime and come in and take a tour and do a pre-screening and figure out this is something that could fit for you. And we will look at how to pay for the program. We will check on that and let you have that information from the very beginning. So there's no surprises coming in. So it depends on crisis mode. Yes, I would say oftentimes the expectation that you will have time to make these decisions, and then you do find yourself in the hospital, and you might not necessarily have the choice to go home. So it might mean, yes, going to a skilled nursing facility to get stronger and then to go home. Once you are home, then maybe you might want to consider a PACE model of care. Because we do need to come in and do a home assessment as well. So the challenge will be is enrolling, right? So it takes about 15 to 45 days to enroll, and you have to wait till the first of the month to enroll in the program. It is a health plan. So whatever health insurance plan you have currently, that would change on the first of the month. Again, there won't be any surprises for you. We will be going through and talking about this and answering lots of questions. So people are coming into the program fully informed.
Perfect. Thank you so much. Virginia, so one question for you is, so as many of us know, after we have a life event or a hospitalization or we're in rehab for a short time, our mobility gets a little bit more limited, which many times the first thing that we are unable to do is to drive and to get ourselves to appointments. But after discharge, as we all know, appointments are very, very necessary, and you typically have a lot of them. So what are some solutions for limited mobility and being able to get to appointments after discharge?
For first, please don't drive after you get discharged. Look for resources that is available for you. ACC Rides provide services in the 13 zip codes that we serve, but we do not do a medical type of service. We are non-assistants. We make sure that you get from one point to another, but if you need assistance with your medical health, we cannot do that. We have some calls that says, I get discharged from the hospital, I need to go home. We decline those type of ride because if something happens, especially you just get discharged from the hospital, our drivers are not medically trained. So our transportation is for you to go to your doctor's appointment, regular doctor's appointment, treatments like dialysis and cancer treatment, chemotherapy, shopping, And we have the Meals on Wheels program also, where we can take you. People who goes after they are released from the hospital, sometimes they don't have any resources like for food. If you're able to go to the site, we can transport you to the location. And there are some ways that we can enroll you to the program. One is we can mail out the registration form. It's a short form, and you don't have to wait. After we receive your registration form, we will call you and let you know that you can schedule for a ride. However, you cannot schedule a ride on the same day because our schedule is done day before, which means if you schedule for the same day, chances are we may not be able to give you the ride. But we have other resources that we can provide for you. We have a list of transportation providers available in the community that we can provide to you and send it to you if you need it.
Perfect. And could you clarify a little bit on what would be that medical transportation versus what ACC rides and many other ride transportation companies can offer? What would be that difference between the two?
The difference between the two is the medical transport is, you see those big vehicles that has gurney that you can use for gurney, and are medically trained to transport people in case something happens along the way to your destination, especially when you are going to the hospital. Our drivers, the transportation ACC rides, cannot provide those type of service.
Perfect. And ACC rides and other programs like it, makes the difference between maybe them and using a rideshare program like Uber or Lyft or GoGo Grandparent? What makes the difference with ACC rides?
The ACC rides drivers, volunteers, and staff are trained how to work with passengers, passenger assistance. With Uber, they'll pick you up, they'll drop you off where you're supposed to be dropped off. With ACC rides, we have a vehicle that has a ramp or a lift. If you're using assistive device, we can transport you. But Uber or Lyft, I don't think they'll be able to transport you, and they cannot take you to the location where you're supposed to go. Let's say your appointment is on the 6th floor. The drivers will not leave their vehicle and take you to the floor where you're supposed to be picked up.
Perfect. So it's a door-through-door versus a door-to-door service.
Correct.
Perfect. And then when you do call to set up a service, what kind of information do you need, and how far in advance can you make those appointments?
That's a good question, Scott. You can't call ACC and say, I would like to schedule for a ride. There's a form that you need to complete first before we can provide the service. It'll ask for your address, your medical condition, what type of vehicle you need, and also we need to know your address where we're going to pick you up. That's one very important thing. And we need to know what time is your appointment and what time you will be finished. So chances are if somebody drop you off, another driver will come and pick you up. So don't say, I want the same driver pick me up and take me back home, because our schedule differs. Whoever is closest to the area, the driver, will be the one who will pick you up.
Perfect. So if you're getting discharged from the hospital and they give you a whole list of follow-up appointments that you have, let's say physical therapy at outpatient rather than it coming into your own home, is that an appointment that somebody could call ACC Rides and say, can you take me to my physical therapy appointment?
Definitely. We have transported several people actually going to the appointment, medical appointment, physical therapy, dialysis treatment. Those are the things that and other things. If you need more information, our information actually, ACC Rides, is on our website. And we have some brochures and flyers at the back if you need more information about the program.
Perfect. And what are some other alternatives in Sacramento if maybe it falls outside of our service zip codes, or it is more of a medical transportation? Does ACC say, nope, sorry, we can't give you that ride, or do we offer resources as well?
Yes. That's another good question, Scott. Because aside from the door-to-door transportation and within the 10-mile surface street that we transport people, we have what we call private rides. So you can go out of the service area that we go, but there's a different type of service that costs you something. With a door-to-door, it's only a contribution. So if you're worried, I don't have any money to go to my doctor appointment, that is a contribution. However, if you're going farther, let's say you're going to Davis, we can give you the list of alternative transportation because we have limited resources. Our drivers is only working 8 to 5 and other providers will work 24 hours a day.
Perfect. And probably a question that you get often asked is, how much does it cost?
Like I said, contribution for those who are ambulatory, and if you don't have $5, which is the amount that our funder approves for us to ask from our riders, you can give how much you want, or if you don't have any amount or any money, we can transport you. We cannot tell you cannot ride with us. We always transport you.
Perfect. And then a question for the entire panel up here is, so if you're in the hospital and you have a life event that has happened and you're either going to rehab or you're discharged, your entire status is changing. Your mobility is changing. Your health is changing. You're going to have a lot more doctor's appointments, maybe something like dialysis or chemo. What kind of complications do you guys get, or common questions do you get from families and from clients themselves as to what resources might be out there to support or where to even begin?
So based on my experience, I know we have limited community resources that are not means tested. So Older Americans Act, that's the federal legislation that that funds a lot of community-based services like Meals on Wheels, and our caregiver support is also funded by that the grant, and this service is available for anyone. We don't ask income or asset to to qualify the people to receive the services, but many of these services are pretty much very impacted because there are so much needs from the community, but the supply has been not keeping up with how much services these the older adults and their families need. So naturally we always try to see if the senior has any chance to qualify for Medi-Cal. Because the Medicare is very limited in terms of providing the medical care reimbursement. Medi-Cal is the biggest public program that pays for the long-term care services that are non-medical. So I think you must have heard about supportive services, someone to come in and help you at home, but you don't have to pay for the service because it is covered by Medi-Cal. There are adult day programs that are covered by Medi-Cal. Sutter Pace, wonderful, the all-inclusive program is also funded by Medi-Cal. So we always we get asked a lot, is there any chance that I can qualify for the program? Then we always do the benefit checkup to see if there is any chance. There are many misconceptions around Medi-Cal program in the community. Many people, before they even run the numbers, they think that they don't qualify because their income is not at that, the poverty level. But California has been very proactive in terms of expanding this Medi-Cal benefit for more older adults. So starting this year, 2024, Medi-Cal no longer assesses your asset. So how much money you have in the bank or in your stock, bond, no matter what, assets are not going to be counted as the qualification for Medi-Cal. Income qualification, the level is still quite low, but they are updating every year to go with the inflation and the increase of other living costs every year. And also, there is not just one Medi-Cal program; there are multiple Medi-Cal programs. So we always make sure that we test all the the information numbers to see if there is any remote chance for the families to apply and get approved for Medi-Cal, so they can use the long-term care services funded by Medi-Cal, which will open a lot of doors. So we get asked a lot about the public benefits that can to pay for the long-term care service, and we make sure to to help the families to understand their eligibility.
Let me also add that in our registration form for transportation, it asks for your income, but you don't have to indicate how much is your income. The reason we have to put it in there is because our funders would like to know if we are serving the low-income people. So even if your income is more than what you think is more for you, you don't have to indicate. There's only a part there where you have to circle the amount not actually the specific amount, if it's more or less. Those are the only information that our funders needed.
And something that can boost your income too is if your spouse or if you've been a member of the military. So if your spouse or if you served during military times, you didn't have to be out in the field. Let's say you had a desk job during wartime. It could have been during Afghanistan or the Gulf War. If you had a desk job or your spouse was a veteran, you can boost your income, and that's called the Veterans Assistance Program. So the people who qualify for that program, they're able to, you get a monthly check, and it can be, so it could be over $1,000 a month, but it's something that can help you with your caregiving, and that's called the Veterans Assistance Program. There are different home health agencies that can help you. Going to the Veterans Assistant Program, you can also find it online. And so that could be something that a lot of people don't tap into, but you have that benefit available to you.
So I think what I would also like to add is that during this time of upheaval, transition, there's so much focus, of course, on the patient and how things are changing or changed for them, is for us to also consider to look at the, or to really focus on the well-being of the caregiver, and that is their spouse, their close friend or next-door neighbor, or just the people around them. There are resources, to help with the caregiver to make sure that they are being supported as well, because then they can also become the new coordinator and organizer of all the appointments and making sure that there is nutritious food in the home and in the refrigerator, and making sure they're getting outside, or it can be overwhelming. So I just want folks to know that if this is a change that's happening in your family or in your social circle even, that there are resources out there, and having ACC in the community is a big help to all of you.
I think that brings up a very important point, and one I hear a lot about discharges is that even though you may have a great support system, you don't want to be a burden, or you don't want to lay all of your troubles on your support system. So being able to have additional resources helps not only you, but it also helps your entire support system as well. So flipping back towards the beginning, Corey, one of the things, if somebody, let's suppose, is in the hospital and feels as though rehabilitation or skilled nursing might be a good fit for them, but they're not talking about that at discharge, what rights does a patient have in the hospital to speak up and advocate?
Every patient, you're in control. You're the driver, so you can drive what direction your care is going in. So you do have the choice of choosing a facility, and you can speak to the care manager about that at the acute hospital. But you're in control. The patient or the responsible party, you have that right to make that decision what facility you go to. You also have a right. People have a right to appeal their discharge too. And what that does is it gets you an extra day to help determine, where you're going to be going. And a lot of the times, you just work with the care manager. They're going to give you a list of the facilities that accepted you, and you can choose one. But you have a right to choose the facility you go to, as long as, sometimes the barrier might be an insurance issue or it might be a care issue that the particular facility can't accommodate. But you definitely, the resident is the one that's in control.
Perfect. And then once somebody has a skilled nursing stay, either for short-term rehab or a little bit more extended depending on their need, what can they expect upon discharge from skilled nursing?
The discharge from skilled nursing is we're going to follow you from admission to discharge. So you'll initially, within that same week, you'll have a patient care conference. You'll meet with the interdisciplinary team here. And then on discharge, you're going to be working with the discharge coordinator at the skilled nursing facility. They will help coordinate your home health follow-up. So if you have a home health agency you're already working with, we can make that referral. And then also, you might perhaps need some medical equipment. Maybe you need a walker or a cane, or you need a special hospital bed. So we can help order those for you. So when you go home, you're set up for success. That's the thing we want to make sure that you're followed up on, that you get your home health, and that you have the medical equipment you need. But we want to make sure you're confident when you go home and that you have these things available to you. So the team here would be working with your family and yourself. We want to find out, what are your barriers to going home? What can we do to facilitate that? We want to make sure it's a safe discharge as well. And sometimes we need, we need like maybe a bathroom rail put in, or a rail put in our shower, and we might recommend those things. So that's something that the physical therapy and the occupational therapy team, they'll be working with you too to make recommendations.
Perfect. And then I wanted to also open back up for the entire panel. If you wanted to share a little bit more about your experiences with discharge and how to make it a little bit smoother.
Okay, so I'll just speak a little bit about Sutter Senior Care PACE. I would say the advantage of a program like ours is that if you are in the hospital or skilled nursing after a planned or surgery or some other event, we already have your home care team in place. And so what happens often for our participants in the program is that maybe there are home care teams in place and they come in maybe 3 times a week for an hour or so. Well, maybe after surgery, we'll just keep that same team and maybe up the hours, up the times, add a few more services. With our program, there are no co-pays, so it's no extra cost for the patient to have these extra services, and maybe it is just for like a week or two. And so I would say that comes up sometimes as well.
The one suggestion that I have for the families and seniors is that from the moment that you enter the hospital, the discharge to the skilled nursing and the discharge to home, you get to speak to so many different people about the different care options and why they recommend it, and it is based on what kind of assessment. I always recommend to have a notepad or at least a paper that you will always write down the person's name, what they said, and what is their position. So they will say that they are discharge nurse, or they will say that they are social service manager. And they come in because they work as a multidisciplinary team, that they engage you in different times during your stay. It can be quite disorienting, and the information can be jumbled in one big the mess, and then when you come home you just suddenly don't have any follow-up. So please, if you can, I know it is a time that you are suffering from the pain, or if it is a lot of the things that you have to manage, but if you can keep track of the people that you work with, and then get have the way to refer back to what the person said, and then to take them really put them in the accountable position about this the options that we discussed. That always helps, because when you come back home, you will start with your primary care team to extend and then continue to the services that you need for your recovery. So organize as much as you can the information that you receive. And also in the skilled nursing facility, the same thing like Corey said, residents have all the rights to make the decision, and then the work with the care team to decide what is the best the safe discharge for you. So communicate with the team as much as you can. And if the discharge planning doesn't seem to be really in line with what you see for your own well-being, please feel free to speak up. I know some situations they can say that they can list insurance reason or any other reasons for the discharge, but discharge shouldn't be based on those reasons. It should be if they reach the goal for your rehab services, and they arrange the safe discharge home. So be advocate for yourself, and then feel free to speak up, and then work with the team to make the discharge as safe as possible.
Let me add a little bit on that one. The good thing with the ACC is we have all the services that we can offer. When they're here in the facility, if they have to go to treatments, we can transport them. And then from here, they can go to MTV. And when they go to the MTV, we transport them also. And when they're in the MTV, if they would like to go back home, that's another way that we can help them. And ACC has the notion of continuum of care. And once they're home, there are other resources like classes, services that we provide so they can stay home and keep themselves at home and hopefully stays home and be able to avail the resources that we can offer.
I think that's an important question, or a important point you bring up, Virginia, is many times when we talk about discharge, we talk about the medical side. But there's so much more to discharge. There's social, nutrition, home improvement, or home modification. So could the panel talk a little bit more about what resources are available for things like social interaction? Because as many of us may know, when we get sick or have an injury or a life event, we tend to stay at home and isolate ourselves a bit more. And then that just kind of gets a little bit more extended and extended. So what are some other solutions after discharge that can keep somebody active but yet still supported?
Yeah, I think maybe some of you are aware of the ACC's lifelong learning wellness programs that provides a variety of activities. It can be physical exercises, it can be educational programs to help you to learn more about the issues related to aging. And we have a lot of club activities, for some things that you can enjoy and can bring, the happiness to your life. We had a few, the people who recently went through the health crisis and the hospitalization, discharge, and then sometimes it can be a wake-up call for us. And they explored some, the activities and programs at ACC, and then, they could join and then build relationship with other participants and, to do some exercise or some social enrichment in a safe, supervised environment. So please feel free to, to explore some of the ACC programs. And if there is anything that catches your eyes, I think staying active is always recommended for all the seniors. That is most well-known prevention or the slowing down the progression type of, the treatment for all the cognitive impairment or the physical changes that we go through when we are in that age group. So hope you can, consider, some of the programs at ACC that we provide. And also outside of ACC, if you want to, to go out and then maybe engage some other activities in the community, and maybe you want to walk, to have a daily walk or go to, to visit some of these outings, and you feel that you are not up to that level that you would feel independently, quite confidently, can maneuver yourself. Then we also have the senior escort program that these trained volunteers will be matched with you, so you can go and walk and go to places safely with someone who will be the companion for you and then make the walk or the outing even more enjoyable. So there are some ideas that we really want you to consider, because it is one of the ACC's basic mission to keep our older adults active and safe and healthy. And that kind of outing and the enrichment can be very core of our efforts for that. Yeah.
All right, wonderful. Well, I believe we are about time to open it up for questions. So if anybody has any questions in the crowd, what we'll do is when you stand and say your question towards us, we will repeat it through the speaker system, so that way everybody can understand what your question is. So if you have a question, please feel free to send it our way, and we'll go ahead and answer it from the panel. Sure. So the question is, in previous experience, there was a certain number of nights that a person had to be in the hospital in order to qualify for any of the skilled nursing services. Is that still in play?
If she's a standard traditional Medicare, the Medicare's primary, then you'll need a 3 midnight stay. So you have to spend the night 3 nights in the hospital, but you have to be inpatient. It can't be under observation. Sometimes I've seen people stay up to 10 days as an observation patient, but it's not inpatient, so we're not able to use that Medicare benefit. And that's something that you might want to be asking too. Is this an inpatient stay? Because sometimes they'll just admit you as an observation. But in order to be admitted under your traditional Medicare, you need a 3-night stay. If you have Kaiser or Sutter HMO or a Dignity Health plan, you may not have to have a 3-day stay. But when you're traditional Medicare, they're going to require those 3 midnight.
And Corey, is that something that as you mentioned or alluded to, is that something that while you're a patient at the hospital, you can advocate for, is to be admitted versus just under observation?
You can do that, and then you can actually ask to speak to the advocate there at the hospital, and maybe they can help you too, and they can speak to the manager there, the caseworker, about why maybe you're not admitted as an inpatient, because those are rights that you have to ask questions. You know, are you inpatient? Why would I not be considered an inpatient? Because you want to make sure, and usually the hospital will help you with that too. They want to make sure that you could utilize your benefit, that it's not a surprise, and that they're doing the right thing for you. So just make sure you have the right to advocate for yourself. And there is an advocate at the acute hospital as well that you could speak to. No, we do have a contract with United Healthcare. There are so many different United Healthcare plans. Some of them are through NAVI, which is Dignity Health. Some of the United Healthcare plans are through Sutter. And a lot of the retired state workers are UHC Choice. So they do have a PPO plan. But we are contracted with them, yeah, and we're able to accept the PPO as long as there's a prior authorization. You do have, it sounds like you have really good insurance. So the good thing.
And I also have the fallback, which is the VA. It also
Yeah.
covers my wife.
Yes, and then the VA there also, if you need any extra help, you know, you have that veterans assistance a boost too they can give you as well. That's right. No, I understand that. That's what they're doing that with a lot of knee replacements and hip replacements. They're saying you could do your rehab with home health at home and put some ice on that. And so, yeah, but you have a right to advocate, because if you actually don't have the caregiver at home, you do need more extensive therapy, and that's no time to be a warrior. If you're actually not feeling well in the hospital, a lot of people will say, I feel great, I'm ready to get out of here. Believe me, the hospital will send you home. Yeah, and that's the time we could tell someone, we're here, you're here for fine tuning. We're not going to keep you hostage here. We want to get you stronger. We're not going to keep you here forever.
She needs some guidance.
Well, she can call me. When the time comes, she can always call me.
So the question for everybody is, if when leaving skilled nursing, what is the preparation for receiving services such as IHSS to make sure that it is a safe discharge?
Well, there is going to, if you're new to IHSS, it's going to take a while. You know, that is something that you may not be able to get within a 2-week period. So if you're actually just signing on to IHSS services, it may take us a while to get that coordinated. But if you're already in the system, what we can do is when you're here in the facility before you go home, we notify in-home health supportive services, and we let them know this person's in a facility, they're going to be discharged. If possible, if they can increase that they can increase the hours of the chore worker. You know, that's something that we want to say. But it's up to IHSS if they've got a worker available. And if we can go ahead and give that information while they're here.
So just to repeat that really quickly, so it's talking about with programs such as IHSS or any other program, is there anything in place that can help to expedite it for those that are in skilled nursing or discharging from the hospital? Is there anything to expedite that process, or any systems in place to speed that process up so it's a safe discharge?
I would add to that is that if someone has already been eligible part of for Medi-Cal, the presumptive is another element, but let's say to go through the assessment to see if they are eligible and start receiving services from an IHSS caregiver could take a while, where with our program currently it's 15 to 45 days. And during that time, we will be sending a nurse to do an assessment in their home. And part of that care planning to be put in place, so on day one of them being part of Sutter Senior Care PACE, is going to be the home care, and that can start on day one. The challenge sometimes is that there needs to be a bridge. We would start PACE on the very next day if we could, but just the current rules has to be on the first of the month, and we are required by regulations to see the potential enrollee in their home environment. But yes, it can be faster, right? And it's still a Medi-Cal program, so it's an alternative. So a PACE is an alternative to IHSS, in-home supportive services caregiving.
Sure. So the asset limit traditionally has been always with the single person $2,000, for a couple $3,000, which is the same number for the SSI eligibility. Now, state of California understood that was such a big obstacle for the seniors because they had to be spending down to until they reach the abject poverty to apply and then qualify for this program. So with that understanding, they eliminated the asset test. So how much money a person has in the bank, or as other asset items, how many properties or the cars, does not be counted as the eligibility criteria anymore. It is only the income. So the income-wise for a single person. So these numbers are for the no share of cost, straight Medi-Cal. A single person from your gross income minus all medical insurance premium you're paying for your Medicare Part B, Advantage plan, any other, the Medigap plan, vision, dental, you subtract all the, those insurance premium monthly. And if that number is less than about 1,730, then you can qualify for Medi-Cal. But even when your income is more than that, after all the deductions, you can still qualify for Medi-Cal, but with share of cost. Now the share of cost is very, very high. So many seniors whose income is at about 2,000, 3,000 level, it did not really make any sense because how the Medi-Cal calculates your share of cost is that from your gross income minus $600, the rest of the money will be your share of cost that you have to pay every month before the Medi-Cal benefit kicks in. So I know there is a legislation going on to make that share of cost a little bit more reasonable, because who can live with the $600 in California per month at the time and age, right? So I hope that in future years, recent future years, it's going to be changed, and that we can open more door for the seniors who have the share of cost to use the Medi-Cal service at the reasonable, the copay rate. So that is coming on. But to answer your question, sir, yeah, there's no asset guideline. It does not apply. And when you apply, they don't ask for how much money you have, how many cars you have. It is only solely based on your income.
So the question, if I got it right, is if a family member's income is over $3,000 a month, would they absolutely not qualify for something like Sutter, PACE, or Medi-Cal?
So to start with, the question is really first about Medi-Cal. And we would always recommend, if someone's not sure, it can't hurt to explore it, to inquire and see what it is, because there are other programs such as Working Disabled and other programs in Medi-Cal that can help someone get on Medi-Cal. There might be a share of cost with our program. It's no longer required for us to enforce the collection of the share of cost. So that is opening up access to many people to come into a Sutter Senior Care PACE program, where they can have a take-home meal program, socialization, transportation, pretty much anything you can think of, we can probably assess for it. So I'm happy to hear that you know someone who's been satisfied and supported by a PACE program. It can't hurt to ask.
And I think it's important to also say that if somebody doesn't qualify for PACE, just absolutely does not qualify for PACE, many of those services can be bridged together to create a PACE-like supportive net for that person. So things like transportation through ACC rides, Meals on Wheels, being able to provide home-delivered meals, So you can put in elements of PACE even if they don't qualify to help support them upon discharge. So the question for everybody was, if somebody's being discharged from skilled nursing and does the skilled nursing provide a list of vetted other skilled nursings for long-term care? Yeah, does ACC provide a list of other skilled nursings that have availability for long-term care? And yeah, a lot of it does, like Corey said, come down to bed availability. But Sujin, you had something to add to that as well?
So there is a skilled nursing for the long-term stay. Is that what she is looking at potentially? So if the person's needs can be met at the assisted living level, because skilled nursing facilities are medical care facilities, that is recommended for the people who need 24/7 around-the-clock nursing care. ACC does not have the vetted list. Skilled nursing facilities, what we usually recommend is that because they get their biggest reimbursement provider is the Medicare. Medicare has the rating system for the skilled nursing facility. U.S. World News has also the very well-respected rating, of each, the facilities, the capacity, how well they are doing for the short-term rehab, long-term, the services and such. So there are some places that you can collect information in this area. What are the skilled nursing facilities that are rated well? They're doing a good job, or the poor ones. But I just want to briefly mention that finding a long-term bed in the skilled nursing facilities in all over California has been such a difficult obstacles for many, the senior challenging situation, because I think it is just the sheer size of the demand. There's so many seniors, that need to make that a permanent transition to the skilled nursing to live there and then get cared for. But there are just not many, the beds or the facilities available these days. So it can be quite difficult for the many families.
Sure. So the question is, does ACC or skilled nursing provide resources to finding home health, specifically things like wound care home health and visiting nurses upon discharge?
We'll be working the case manager here, the Lon is our transitional care unit nurse. And she and Millie work together, and Millie is the social worker here. So what they will do is, depending upon your insurance, they'll find the home health agency that you've either worked with before, or that it's the provider that your insurance company uses. So if it's a United Healthcare, let's say it's Sutter Managed Care, you're going to be using Sutter Care at home, and that's the referral. Our social worker here will send that referral to Sutter Care at home. That would be your designated agency.
So that's a great question. Yeah. If you're being discharged and you're going to skilled nursing long-term care, but you don't like the place that you end up going to, can you be on a waiting list for ACC's long-term care?
Well, definitely what you can do is you can have that. I would need a clinical referral in order to even tell you if we're able to accommodate the resident in terms of moving forward with a long-term care bed. So what I'll always need is a clinical referral from the facility that the resident's currently in. And then we can talk about, putting them on a list or keeping them in mind the next time we have a long-term bed open. People have a right to speak to the advocate of the skilled nursing facility. If they're unhappy there, they should be talking with the social worker that's at the skilled nursing that he's currently in. And so they can have that dialogue. And it's really important too, people go through usually a transition period too. And sometimes you have somebody that's having some difficulty sometimes transitioning, but they really do need to speak to the social worker that's at the facility that they're at, so they know there's an issue. And if there's something that they can do now to make the resident more comfortable, they need to work on that, but they need to know there's an issue. So make sure that it's not a surprise to the other facility.
And I think, a common thread through all of what we've talked about today is that open communication, making sure to communicate and advocate. So if you're maybe not being heard or not feeling comfortable speaking up, there are many different layers, especially in skilled nursing, of modes you can go through to hopefully speak up and be able to advocate for yourself. And that's definitely something that, obviously afterwards we can talk a little bit more in depth to you about. But there are different layers through like third party, like the long-term care ombudsman or something of that nature. And over here in the corner, Jerry.
The Older Americans Act funds long-term care ombudsman in every county in California. And so we have an 800 number. Sophia might be good to speak to this too. She works with me, and she's been doing some ride-alongs recently where she goes with the ombudsman to facilities to meet people there and talk to them about their living conditions and how things are going. But the ombudsmen are designed to help intervene when you're having issues with a facility. Is there more that you would like to say?
Yeah, so we have two different numbers. So we have our information and referral, which is our front office, and then we also have our information and assistance line. So there are two different numbers, and I can leave them somewhere here in the back. I'll leave both numbers so you can have access to them. You'll either be speaking to Heather or Joanne. They're really great, and if you make a referral to our ombudsman, that will be sent to them. So we do have residents as well that contact the ombudsman directly, and then the ombudsman go out to the facilities and they assist them, and they speak to all the staff, and they make sure that they basically figure out, they're investigators, they figure out what's going on, and they speak to everyone in the staff to see, they speak to the residents as well. Yeah, so, and they're all great. Like she mentioned, I've gone on ride-alongs, and it's great to see, the ombudsman, the work that they're doing, and helping out the residents as well, letting them know that they have a voice and they have rights. Yeah, thank you.
So you have a lot of resources in the room that you can speak to as well afterwards. So I think we have probably enough time for maybe one more question. Sure. So there's a few different within the Veterans Assistance Program. Aid and Attendance is one of them, but there's many different programs within the Veterans Benefits. The best way is to find a veteran ombudsman that can help you, or ombudsman, excuse me, that's on my mind, a Veterans Assistance agent that can help you to qualify for the process, because it can be a little daunting. You can go online and find the qualifications and the minimum qualifications, the paperwork that you'll need to prepare. And then you can see which of the veterans programs that they may qualify for. There's a few different levels. Aid and Attendance is the top. That is the most, the one that pays back the most. It can pay for many different things. It can pay towards skilled nursing. It can pay towards assisted living. It can also pay towards in-home care. Or sometimes, depending on the situation, it can pay a family member to be able to provide the care. So those are programs, again, none of us are veterans experts up here. I always give that disclaimer, but it's always worth looking into. And the Veterans Assistance qualifications and people to help you with the process should never charge you to fill out the application. That's an important part, because it is technically illegal for them to charge you to fill out the form. Of course. And there are income qualifications and things just like Medi-Cal that you want to be aware of as well. Yeah, of course. All right, so we're nearing the end of the program. I think we have one last question. You guys were a tie for raising your hand, so we'll do the one last question. So typically, yes. So it's traditional Medicare. Traditional Medicare is exactly that, excluding any supplemental or any other, basically if there's another name attached to your Medicare, most likely it is not traditional Medicare. But yes, traditional Medicare does require 3 nights to be able to pay for a skilled nursing rehabilitation stay.
Great question. So the Medicare Advantage plan is what these private providers of the healthcare insurance have a contract with Medicare. They are known to be usually have more benefits compared to the original Medicare. So it is best to check your policy, the benefit, to see, because they have all the regulations and the stipulations about this discharge, the process, how many nights to, start the, the skilled nursing facility care and such. So each individual Advantage plan has their own stipulations and benefits for their members. So if you are curious, and I think, that we all, they have to at least, the annually when they send you the benefit booklet. Please review and then see how they, they cover the cost of your hospitalization and the discharge afterwards to the skilled nursing. It depends on the plan. So yeah.
Perfect. Well, thank you, everybody. We're just on the button of 4 o'clock. We do have representatives from Meals on Wheels, our Senior Escort program, our ADRC program, Pearls program, all here in the room, as well as our panelists that'll be hanging out to answer any questions that you have. So please feel free to approach any of our representatives and ask us any questions that you didn't get asked today. But thank you so much for attending, and please feel free to always reach out to ACC if you needed any resources. Thank you.